تفضل دكتور أمين.
مساء الخير. نتمنى أنه الأهل في سوريا وفي العراق وفي اليمن وفي فلسطين أنهم يكونوا بألف خير إن شاء الله. يعني المحنة صعبة وعلينا أن نصبر يعني. اليوم محاضرتنا عن psychiatric assessment، وطبعا زي ما بتعرفوا يعني هذا يعكس الطبيب النفساني وقدرته على إنه يعمل التقييم للمريض ويخطط مستقبل العلاج بالنسبة له. فأمور عديدة يعني تحتوي في هذا الموضوع، وأنا ححاول يعني بقدر الإمكان أن أعطيكم الأشياء العلمية الصحيحة في هذا الموضوع. أم، هذه تتحرك الصورة يا دكتور وليد؟
لا، ما تحرك.
ما تحرك.
هلا تحرك.
طيب. Yeah. Psychiatric interview before the start of the assessment, the interviewer or the psychiatrist should have in mind what he is going to achieve from this meeting with the patient. Definitely, to make the assessment looks like an art, you need to know about the patient's personality. You need to identify the etiological factors or the reasons behind the acute problems that the patient is coming for help for that. Examine the patient's mental state and end up with a diagnostic formulation. And there are some times which you require to do the physical examination to complete the whole aspects of the assessment. Definitely in any kind of assessment, depends where you are. If you are inpatient or you are in emergency room, or you are visiting the patient at home, or you are going to see or to assess the patient in prison, all these kind of differences, different places, makes you decide what kind of assessment you are going to achieve. But there are something in common between all these kind of places. The setting is important, where you are sitting, where the patient is sitting. You need to expect if there is any aggressive behavior from the patient, you need to be safe. Your presentation to the patient, introducing yourself to them, that will facilitate the understanding. You need to keep some kind of distance between you and the patient, not too close, not too far away. Doctors also stand up when the patient enters the room. You need to show your respect to the patient before, when they arrive, and introduce your name and your position. And what are the reasons behind this assessment? Sometimes you have been called to do the assessment for legal matters. You need to explain to the patient what's your position on that. And also at the same time, you need to indicate the purpose of the assessment in terms of the how it's going to be in practical manner. Like, for example, you don't mind if I will take some notes during the conversation. If you are on the laptop, that might interfere between the eye-to-eye contact and looking at your laptop all the time, or I do personally, I do some notes, just trying to pencil some notes during the assessment instead of looking at the laptop. Eye-to-eye contact is very important, and sometimes there are some pathological element from the patient's attitude toward this kind of thing, and occasionally you may find that women from subcultural elements, they are unable to do eye-to-eye contact. They prefer not to. No need to ask too many questions initially, especially in the first assessment, because that will look like bombarding the patient with questions as if you are interrogating them. Give them the chance to reflect back on your questions. And once they feel more relaxed, you will find the information they are coming. And try to begin by telling them what is the problem which brought you to see me today. So this is the way how you can open the discussion by an open question like that. Try to avoid using terminology which is unfamiliar to the patient, like names of psychiatric conditions. Try to use the language which is spoken by the common population. During the assessment, which I usually I use that very often, I will say at specific point, thank you very much for telling me this, but let me understand this better. What about if I recap what you have said and stop me if I got it wrong? Yeah. So in this way, you give them some power to ensure that they are giving you the right information. So I will summarize what I understood, but also at the same time, they will add into that. Try to avoid making the interview as business-like exercise, like the time, for example. Definitely the time is crucial in a situation like this, but also at the same time, the patient should not feel that you are, especially if there are charges for these kind of assessment, that they are controlled by the time. Very often, when I used to be a junior doctor in training, we used to have the videotape replay during supervision, and we learned plenty of things really from the feedback on this aspect. Right, before we start, if you look at these questions, and I think we can answer at the end. The following are true of delusions. A, they are abnormal beliefs. B, their content is often bizarre. C, the beliefs may be shared by the other similar cultural background. Or D, they are unshakable by reasoning. E, the beliefs are invariably false. So there are four, right and false, correct and false, true and false, but we will look at it later. History taking. Definitely the first thing you need to look at the presenting illness or the presenting complaint. Yeah. When you ask the question about what brings you today, what kind of problems do you have, they will tell you, but definitely they will not say all aspects of the illness in itself. So you need to be careful about attention, to be attentive to what they say, and also try to avoid repeating things. That will give the patient the feelings that you are with them, you are there for them, really. The nature of the current problem, you need to identify the time when this started. Yeah. There are two things in mental health regarding any psychiatric condition, the nature and the degree, which are very important in any assessment. The nature is when the problem started and how it started and how it's progressed over the time. That's the nature. The degree is the intensity of the problem in itself. If it's acute, if it's subacute, if it's chronic, if that caused serious difficulties in functioning, that's the degree of the problem in itself. The precipitating factors, they are important also. Very often people they can't identify a precipitating factor. They can't see any kind of reason why the depression started. So it's out of the blue. And we know some conditions of endogenous depression, for example, or of acute psychosis can be presented without evidence of precipitating factor. Sometimes the patient, they might say things and they are completely irrelevant, which you need to hear definitely and to record them, but also at the same time, you bear in mind that they are relevant and you are not there to challenge them about these kind of things. That will come later during treatment or during therapy. You can bring it up in sessions. The impact of these problems on the family around the patient, and also in their work. How has that affected people around you? Is there any troubles happened? Have they criticized you for the way your attitude towards them? Is the family, they are concerned about you? These kind of elements indicate the severity also of the problem in itself. If before they arrive to you, they have seen other doctors, for example, or a physician, or a GP, the family doctor. What kind of help and support and treatment they have received. This is very important. Also within the family, sometimes the family, they cope with the individual problems or the individual illness in different ways, and we need to explore that. There is something in psychiatry called high expressed emotion within the family, when they are very critical of the individual or over controlling at that extent that they can cause serious emotional difficulties for the individual. The patient's view of his problems. What do you think is the problem with you? What's wrong with you? Do you want any help from us? What kind of help do you wait for us to offer you? We will look at the personal history after that. And definitely the personal history, it's about a comprehensive kind of assessment of the individual who is in front of us for psychiatric review. The early life and developmental experiences. You start from birth, really, if there are the information available, what kind of birth they had when they were born. There was any difficulties in the labor of the mom during pregnancy. It was a normal delivery or cesarean section or forceps. What kind of difficulties in terms of respiration when they are Apgar school? If there are the information available, they are good to identify. During their growing up, if there is any difficulties in terms of physical health problems, or maybe they have been known to the child service, mental health, or they have been known to the pediatrics. Have they enjoyed life as a child? There was any separation anxiety from the mom, maybe in hospital, or there was a divorce within the family, have affected their caring. During the assessment of the personal history, and the growing up, you can identify areas of vulnerability. And this is very important at later on, even to assess the risk at later stage. The vulnerability is about any kind of mental health difficulties they had in childhood, like school phobia, for example, or refusal to go to school, anxiety. A number of people now, they talk about ADHD as a common kind of manifestation of mental health difficulties in childhood. And then you ask the patient about any kind of sleep disturbance in childhood. This is very important because sleep disturbance can create serious difficulties in terms of nightmares or sleep with nightmares, which really can indicate some other pathology happened during childhood. The schooling is very important, as we said, about the anxiety, school phobia, the academic achievement, also what kind of subjects you were more familiar with, happy with. Some people, like people with ADHD, they do better in maths rather than in literature or languages. You look at the family history, the parents. Are they alive? How old they are? If they are working, what kind of jobs they have? You inquire about the family history of mental disorder. And also at the same time, you try to understand the environment of the family, how they are living, how many persons they live in the house. Is there any issues related to communication difficulties, anger, guilt, distress around the anniversaries within the family? Yeah, if anybody died recently within the family. Also, you inquire about divorce and the siblings. How many siblings do you have? How old they are? Which number you are between your siblings? It's important. The employment history. Did you go to university? Did you study? Do you have any qualifications? Yeah. What did you do after? No, I didn't go to university. I went working. You worked in a company or with your father, for example, and you try to take the jobs in chronological order and how long they stayed in these jobs, because that might indicate also something about their personality-wise. Have you survived any war? Nowadays, as you can see, it's common, it seems, in our area. Any immigration status. And then you look at the personal relationship of the individual. Are they married? Are they single? Are they divorced? Yeah. Do they have children? And then you focus on their sexuality. Sometimes we ignore that because of the sensitivity around this issue, but I believe it's important always to explore that. Yeah. You look at the past psychiatric history. Sometimes it's not the first time this individual seeing a psychiatrist. Maybe you see them for the first time, but they have been admitted in another area to psychiatric hospital, or they have been assessed by. So you try to get the information, and if there are any reports available, that will be a bonus for your assessment to depend on. You inquire about any forensic history, any imprisonment, any arrests by the police. Yeah. The past psychiatric medical history also is important if the patient has been subjected to any surgical interventions. Yeah, if they are taking any medication for high blood pressure or diabetes, arthritis, you need to record that. And then you ask about pre-morbid personality. You look during the assessment, you can manage to evaluate their self-esteem, their confidence, the way how they talk, and the trustful relationship that you have managed so far to create with them. Is there any history of drug or alcohol misuse or abuse? History of aggression or frustration or anger related to some relationship difficulties or traumatic experience unresolved? You look at the cognitive function and straight away you can manage to differentiate between the functional illness and the organic illness. It's not always easy, but you need to bear that in mind. And you can simply ask the time, the person, and the place if they are showing any kind of disorientation. You can test the short-term memory, easy. You can give them a name and an address. You need to bear in mind how many items they are there, count them, like 15, for example, a name and address. And after 5 minutes, you say, and you explain to them in advance that I'm going to give you this name and the address. And after 5 minutes, I'm going to ask you to recall it for a specific reason, is to assess your short-term memory. Mental state examination, it's like physical health examination, and we need to take in consideration the difference that every patient has different mental state examination, even that they have or they are suffering from depression, for example, or social phobia. The terminology is the same, but the mental state examination could be different. The appearance and behavior, it's important. How they are dressed. Is it appropriate? Are they clean? Are they tidy? These kind of simple observation makes a big difference in terms of diagnosis. How they react to eye contact. They are looking at the ceiling or between their legs and they are not interested to look at you. You try to establish rapport with them. You can see if they are in touch with their surroundings or they are completely detached, living their own imaginative thinking. You can see if they are experiencing any perceptual disturbance, like hearing voices. Getting up during the interview from the patient, it's very, very important. That indicates most likely that they are restless, they are anxious, and they are worried to stay in front of you. Yeah. During the interview, you might see that the patient doing some gestures in communications, moving their hands or moving their head. All these kind of elements might be important to complete the whole picture of the presentation. Look at this, their speech. If they are monotonous, if the speech is spontaneous, or you keep asking the question repeatedly for them to be attentive to what you are asking. Is the speech slurred? They might be on antipsychotic medication and the speech is disturbed by their presentation. Is the speech coherent, logic? Is there any pressure of speech? Yeah. All these kind of elements, they are important also in the mental state. The mood. You can ask them, how do you feel in your spirits? Yeah. If they are congruent or they are incongruent, if they appear to be depressed and they're expressing delusional system congruent with their mood, or they are depressed and they are coming for depression, but also at the same time, they have a delusional system which is completely incongruent. The flat effect and the blunted effect in severe depression or in psychosis. The labile effect, where the mood fluctuate between being low and being high. You need to ask about hopelessness. How is your future looks like? You can ask them. If they express their feelings that the future is dark, it's like a black tunnel, there's no out of it, you need to ask about suicidal intent or suicidal thoughts or any suicidality related to the subject. Don't forget, especially in depression, to ask about the biological functions of the human being, which is the mood, yeah, hopelessness, suicidal thoughts, comes under mood also sometimes. It's not only that you feel depressed and sad. The appetite, you can inquire about, have they lost their desire to eat? Have they lost weight? Or they put on weight? Yeah. And if there is any appetite or weight disturbance, you can ask in more details about it. Is there times where you have been starving at that extent that you felt unwell, physically unwell? Yeah. If there are elements related to induce vomiting, putting their fingers in their throat and induce vomiting, or taking laxatives. Some people do that to lose weight. The sleep also is very important, and you need to address this in more details. It's not only about that disturbed sleep. Is it early insomnia? Is it interrupted? Is it early morning weakening? Yeah. Have they been taking any sedative medication to help them to sleep? Or they depend on taking street drugs, like for example. And sexual function is important within the biological functions. Yeah. Sometimes, as you know, in depression, people lose the desire, loss of libido in depression for sexual activity. Sometimes there is the phenomena of depersonalization and realization, which are common in anxiety, common in depression. You can see it. But also sometimes you can see it as a pre-stage in psychosis. So you need to bear that in mind. The patient might feel unreal. They will describe odd bizarre things, but it doesn't sound psychosis. You can see that also, sorry, in EUBD. And sometimes they might say that things around them have been like dreamlike, the realization. Occasionally, you might hear about déjà vu, where the patient, they have been in places and they feel that for the first time, and they feel, oh, they have been there before, they know the place. And sometimes can occur in anxiety, or they are staying in a place where they have been familiar to them, and they deny that they know the place, that déjà vu. The thought content. The delusions, which might help us to answer the question that we had before. It's a false belief and doesn't arise from does it arise from depressed mood? So it's become secondary. Somebody is depressed and they have a delusional system based on their mood is becoming secondary delusion. Sometimes within the individual, they come with a primary delusion that it's not linked to the mood, but there is congruent with their mood. That is a delusional mood. Delusional perception, that you can see things and you build a delusion about it. Like somebody is depressed, they get out in the morning, and when they go to work, they see their boss, their manager. It's there. The manager is there. But definitely they had a delusional system that they have done something wrong, and the boss, they are going to call them. And they start to be over worried about this, and they might leave the place. That's a delusional perception. The ideas of reference, that during your activity, you may find someone making a gesture and that it means something to you, that you have done something wrong, or somebody is going to read your emails and they will find something wrong you have done, and they will claim that you are not a good worker. So that is the building up the delusion there. Yeah. Ideas of influence, where you can straight away look at something and they will give you a sign to indicate that they are interfering with your work or with your, and they have read, for example, your emails. Thought insertion, it's a delusional system based on the fact that there is another power, external, inserting thoughts into your mind, or taking away. They have the ability to take away your thoughts. And thought broadcasting, you go out and you can see that people, they know about you, as if the TV has transmitted or broadcasting things about you, or somebody has spread information about you. The abnormal perception, hearing voices. It's common in severe mental disorders. But always you need to bear in mind that as Dr. Walid said the other day, people, they read a lot from Googling things, and they know where is the trick in identifying mental disorder, and sometimes it can be for their benefit. So they might come to say, oh, I hear voices. So you need to bear in mind how to differentiate between the genuine auditory hallucinations and the pseudo kind of hallucinations. Sometimes you might ask them, are they like real voices? Do they come from the inside or the outside? Are they talk to you or they talk about you? or they talk
نشرب نسكافيه ولا
or each other? Are they pleasant or neutral or abusive? Do the conversation talk about you in the third person? So this is how you can tackle the problem with the hallucinations. Patients sometimes they have their own imaginative thoughts, and they describe it as voices or hallucinations, seeing things. Very common in neurotic patients. They seeing shadows or a dead relative. They see the dead relative sitting on the bed with them to comfort them. It's common also. That pseudo-hallucinatory experiences. But also you need to identify if these are hallucinations or pseudo-hallucinations. They are linked to the sleep. For example, it's common when you are tired after a heavy day of work, you go to bed and you have these seeing things or hearing things. Yeah, that's called hypnagogic hallucinations. When you go to bed, hypnagogic. When you wake up from sleep is hypnobombic hallucinations. Have you had any strange experiences recently? You can ask the patient if they want to tell you more about these kind of experiences. To be honest with you, the visual hallucinations, they are not that common in functional illnesses. However, it can happen, especially in situations where people take drugs, for example, or drink a lot of alcohol. But also there are disturbances in terms of taste disturbance and smell, which is the five senses of us really as a human. The touch, tactile hallucinations. People take cocaine, they have this experience. Yeah. People who take LSD, they have visual hallucinations. Yeah. Now, let us look at the descriptive psychopathology. You know, the movement disturbances, definitely there are voluntary and involuntary movements, and we need to be able during the mental state examination to differentiate between the two. You know, plenty of patients, when they attend the psychiatric assessment, they feel sad and they are in tears. Yeah, this kind of aspect of presentation, you need to evaluate that. Is that part of their depressive disorder? Or there are some other elements to indicate that. Very often we see tearfulness is common in neurotic kind of presentation. Sometimes you might find that the patient, they are laughing. Yeah. And that might indicate also some other kind of pathology, depends on the presentation. Giggling, irrelevant kind of smiles or laughs, that might indicate psychosis. Yeah. Being cheerful and happy and with laughing and giving you stories and being over familiar, you can see that in mania. Overactivity, again in mania, you can see it. Sometimes you might end up dealing with irritable mood, and irritability, it can be common in people who have difficulty in their personality, or they are are suffering of paranoid illness. Now, in terms of movement problems, you can see the whole aspects of the individual body is in catatonic place or reduced kind of movements. That's which can lead into catatonia. Catatonia in itself is considered to be an illness, and you can see that most of the time in functional disorder like in schizophrenia. But you can see it also in other manifestations of organic illnesses. Sometimes the chronic schizophrenic patients, they show mannerism, repetitive, bizarre behavior. Like, for example, repeatedly flushing things, the toilet, or going to open and close the window repeatedly. We know about de la Tourette syndrome, where the sudden involuntary movements of the tics also. This is in young, mainly boys, but it can happen also in girls, with utterances, vocal kind of utterances with the movements. Sometimes we see fine, shaky tremors in both hands, and that could be related to side effect of medication if they are already on medication. Sometimes the anxiety state can cause tremors. We can see tremors in hyperthyroidism. If the patient on lithium, we need to be careful about lithium toxicity. So you need to look at other symptomatology related to the intoxication of lithium. In Parkinsonism, special kind of attention to that, especially with the age of Parkinsonian disease. Spasmodic torticollis. I don't know if you have seen that or you will have the chance to see it, but I had a small number of patients with this condition. It's irreversible. It's a permanent kind of damage, which is, there is no drug which can really alleviate it, which is spasm of the neck and the muscles in the head, which is permanent and irreversible. And most likely it's associated with tardive dyskinesia. And that, unfortunately, could be related to the first generation of antipsychotic medication, especially with the injection form. Again, we can see automatic obedience for people with catatonia. Patient does whatever you ask them to do. Yeah, that is automatic obedience and can be pathognomonic sign of catatonia. Echopraxia, the patient imitates the movement, what you are doing, yeah. In front of you, for example, if you are writing, he starts giving you the indication that he writes. Echolalia, they repeat the words or small sentences, which is imitating you or imitating their dad or the one who is beside them, really. If we look at the thought content, as we said, the delusions, it's unshakable belief, not shared by others, especially with the cultural around them, not modified by reasoning. If you challenge them or you try to explain things to them, they become more convinced of their delusional system because they believe, or they start to believe, that you are not really trusting them. The content It's usually bizarre, odd. It doesn't make sense, really. And often induce great personal significance. There are some grandiose delusions. People become inflated in their mood about the delusions. Delusional mood and then primary delusion. So they depend if somebody has bipolar affective disorder, for example, complicated by their grandiosity. Their mood usually is the primary problem, where they become cheerful, hyperactive, and spending a lot of money. They believe that they might be related to royal family and they have millions of money around. All these kind of delusions based on their mood. The secondary delusions, very often we misinterpret the overvalued ideas. The idea is shared by others, and very often people become concerned. But also at the same time, when the people, they are mentally ill, they might look at the overvalued idea as they are over preoccupied with it, with their emotions and in their quality of life. The passivity phenomena, the patient has no control over their thinking. So they believe that whatever they say or whatever they do, it's not their control, and they are not really responsible for their actions. And that related to their feelings, to their perception, and to their behavior. And this is how the thought insertion, thought withdrawal, broadcasting, especially in legal aspects of care, of assessment, can be very, very important, especially if there is a criminal offense happened by this individual. Again, disorder of the thought content, it's about the obsessive compulsive disorder or the phenomena. Yes, they are not of psychotic kind of illness, but they are considered to be thought content disturbance. The persistent intrusion into consciousness of unwanted thoughts. So the patient, they are fully aware that these thoughts, they are their own thoughts and they are their own feelings, but they can't stop the impulse to think about them or to do compulsive behavior about it, despite the individual's recognition that what they are doing, they are senseless. They have no, there is no need to do this, but they keep doing it. And they resist them. I would like to say, really, according to DSM-5, they ignored the resistance. There are some studies now that there is no need to be resisting the obsessive, compulsive thoughts or ruminations or behavior to be diagnosed with OCD. But this controversial remains an issue. This phenomena owned by the patient themselves. That's the difference between the delusions and the OCD, obsessional ruminations. The thoughts usually, they are bizarre in nature. So this is something in common between the OCD and the delusions. Right, this is another question. Dr. Walid, you can help us to, if anybody wants to answer this. The following are true of
دكتورة صفاء
obsessional.
دكتورة صفاء
أيوة معك يا دكتور وليد.
yeah.
The
جوابك
following through obsessional thought. They are frequently resisted. They support diagnosis. إيه
مم. إيه، موافقين عليها. بسان موافقة عليكي، وشيرين.
أيوة موافقين إيه برضو.
أها.
هو الدكتور هلأ just mentioned إنه بالدي اس ام they removed إنه being resisted صح؟
مهم.
Yeah, you are right. But it's true.
أوكي تمام.
It's true.
يعني they are frequently resisted, not always.
Not
Used to be always, and that's the change.
You are right. So A and E are right. The others are false. Yeah. The disorders of emotions, the abnormal emotional predisposition. So during the mental state examination, as we said, the individual comes to you with a problem. And you, based on that problem, you try now to, as if you are in a roundabout, really. There are different kind of exits. Each exit has a diagnostic entity where you are going from here. So you need to depend on the presentation in terms of their complaint, presenting complaint, but also there are some predisposition or vulnerability is there. Part of this kind of abnormal emotional predisposition, you need to elicit some kind of disturbance with their emotions, like dysthymia, for example. There are individuals who are pessimistic in life in general, but they manage their life. And some people, they have hyperthymia, so elated, yeah, but it doesn't cause really any serious difficulties in their quality of life from day to day. The cyclothymia, again, yeah, I think I heard plenty of colleagues who are trying to avoid these kind of diagnoses, but there are cyclothymia, where people, they have these kind of mood swings, but not really at that severity to cause any kind of disability within their daily living conditions. Sometimes they have this restricted affect, flat affect. Yeah, maybe they have one or two autistic features and they survive with it. However, during your assessment, if they come with severe depressive symptomatology or some signs to indicate bipolar, these are the elements which makes them vulnerable to have the disorder. And this is why it's important also during the assessment to look at these predispositions. Abnormal emotional reactions, yeah, anxiety, yeah, you know, all of us, we have anxious feelings, but it doesn't stop us again to go to work and come back. But you might hear somebody, a colleague at work, that they have faced some difficulty when they come to work and they return back. They are taking time off. Yeah. So this is when you start to, or they have anxious personality disorder. That's part of the predisposition. Again, depression, euphoria, apathy, all these kind of elements which people, they might live with it and they are not causing trouble. So you need to identify that. Abnormal expression of emotions. Sometimes we feel the denial as part of their presentation. In hysteria, for example, which has been removed from ICD-11 and DSM-5, you may find that people, they have a problem, but as if it doesn't belong to them. Yeah, they give you complete different aspect of their reaction to the problem in itself. That's labile indifference. Psychopaths, sometimes, yeah, they lost somebody from the family and they behave like it's okay. So the reaction is not congruent with the stressful event. Perplexed affect. Sometimes you might feel that the individual, they are perplexed in their affect, not because they are severely depressed or they are psychotic, because they don't have the desire to be involved in this kind of situation. But also sometimes you might feel that, especially in the early stage of schizophrenia, that their affect is perplexed or maybe in confusion state. If somebody takes overdose and they become confused, they come with this perplexed affect. Emotional incongruity in acute psychosis because of the lack of understanding and lack of insight, which we will talk about this. People, they might show incongruity of their affect as a reaction to the psychotic symptoms. A blunted affect in chronic schizophrenia, also flat affect, you can see it in chronic schizophrenia as part of the negative component of the course of the illness. Labile affect, you can see the fluctuation between being low, between being high, frequently. And you can, when you evaluate the situation, when you assess, they might say, oh, it has been every 2, 3, 4 hours, I find my mood fluctuate. I have been high and then I go down. Yeah. But also you should not really exclude organicity, because sometimes organic brain problems, they might indicate that. Disorders of the self-awareness. The awareness of the activity of the self. Our emotions and our behavior, ideas, all of us, we are aware of it. But some difficulties might happen that you may find the coping skills or the coping mechanisms of the human being have been imbalanced. And this is where symptomatology like depersonalization and the realization might be manifested. Yeah, and that might be for a couple of hours. But there are cases which have been prolonged up to weeks and months, really, in this kind of dissociative state. Yeah, you can see it also in hysteria. In temporal lobe epilepsy is common, these kind of pathology. The assessment of the personality is also important to give you an indication what kind of individual you are dealing with at this present time. What do you think of yourself? You can ask that. What others they think of you? How patient managed when they left school? Have they went to work? Did they go to university? How is their reaction to stressful life events, including marriage, definitely? And if there is a history of divorce, relationship with the family, friends, yeah, all these kind of elements, they give you an indication what might his personality or her personality indicate to you in terms of mental disorder. Also, during the psychiatric assessment, you need to look at the intellectual functioning because it's important in acute and chronic functional disorders. The consciousness is the state of awareness of the self and the environment. The state of awareness. Sometimes we see people who have clouding of consciousness. yeah, clouding, yeah, and disorientation. And you can ask, as I said previously, about their orientation to the time, place, and person. That will give you a clue about what is happening here. Drowsiness, reduced level of consciousness. So they might look at you, they might walk into the clinic, but you can, once you look at them, you can see that they are drowsy. So you can ask them to assess the situation. Sometimes these kind of presentation, it's common to see them in A&E, for example, or emergency rooms. Yeah, if somebody took an overdose, or they use heroin, or use other kind of illegal drugs. The stuporous state, the reduced level of responses, and that could be functional and could be organic. You can see it in depression, and you can see it in schizophrenia. And stuporous state, if it is severe, can prolong into catatonia. Coma is a profound reduction of the conscious level. Yeah, and this is where you need to arrange for medical attention, for mechanical kind of breathing and medical help. Attention and concentration. It's important also during the assessment. If there are elements of clouding of consciousness, you can assess that by asking about serial 7. But as you know, sometimes can be difficult for someone who is in maybe an old age, or they are not really well educated. You may find that serial 7 difficult. So you can do serial 3 out of 20. You can ask to reverse the months of the year, reverse it. Yeah. If it's difficult for them, you can ask them the days of the week. Yeah. Now the memory, if there are any disturbance of the memory while you are in the process of psychiatric assessment, you have to consider mental capacity. And mental capacity is the question about, is this individual in front of you capable of making a decision about his care, about his treatment? Yeah. And based on your responses to that question, you need to liaise with other kind of family members or with the authority to ensure that you are doing the legal right for the patient. Yeah. The mental capacity is very simple and very easy, despite the fact that we often receive referrals from other in liaison psychiatry, for example, from different wards to assess the mental capacity of patients in surgical ward or in medical ward. Yeah. But the guidelines is any doctor can do it, and any social worker can do it, any nurse can do it, which is to give a registration of data to the patient, like we said, about any subject related to their current problems. Yeah, ensure that they retain the information in their mind, and then ask them to recall. If they are capable of registering, retaining the information and recall, they have the capacity, and they are capable of making decisions. Yeah. You can think about people who have alcohol problems with intoxicated level. They might end up in A&E with difficulty of their attention and concentration and memory and cognitive function and mental capacity. And also, you might be asked to go to A&E to assess somebody with head injury who has this kind of symptomatology. Korsakoff psychosis, for example, it's common. I don't know about in Jordan, but here we see that very often in A&E, people who drink, and they come with this kind of pathology. Recall disturbances, if they are unable also to recall the data that you have given them, you can think of organic cause, as we said, about head injury, for example. And sometimes people who are malingering or hysterical kind of presentation, they might have hysterical amnesia. Now, the insight, which is one of the components of the psychiatric assessment, to be honest with you, it's controversial, this subject, because the insight from one professional kind of agency to other is different. But we will look at it from the psychiatric point of view, which is the degree of correct understanding of their condition. So if somebody is coming with depression, do they understand that they are depressed? Do they understand that the treatment for depression? Do they understand that they need help? If they are psychotic, this can be a question. Because, psychotic patients, they don't believe. They believe that they are right and everyone is mad. So that will be a problem. So it's unlikely that they will admit or they will understand, they will agree on your assessment that they have a psychotic illness or schizophrenia and they need treatment for it. The degree of correct understanding of the etiology also is very important. So if somebody had a stressful life event, like, for example, being dismissed from work, and after a month or two, they develop psychotic depression, they might tell you that they walked away from work because their work environment is not good. So they don't agree on the etiology. And this is when I mentioned about the falsification of the etiology. They will not agree on the etiology. The degree of correct understanding of their environment also. And this is what is about the delusional system, the individual experience with the delusions and the hallucinations. For them, what they are experiencing is absolutely right. They are convinced about it, which no one is agree with it. And when you discuss it with them, they try to justify their position and why the family they are taking a position against them. So they are always right, according to their presentation. The degree of understanding of their management plan. When you say, but look, I heard what you have said, and I appreciate the fact that you have been suffering from this problem, but I have a structured plan. The first one is to start your medication. You say, well, why I need to take the medication? And this is where you can realize that they have lack of insight. Sometimes we use terminology like poor insight, or they have no insight. But I honestly believe that we need to write these 3 or 4 things, to ensure that we justify the position that we are taking in terms of interventions. What I mean that if they are refusing, you can use specific kind of legal legal aspects of care like Mental Health Act assessment to force them on the treatment and hospital admission. The unresponsive patient, unfortunately, sometimes you may end up in A&E or emergency room that you find the patient, they are not talking and they don't look at you and they are mute, they are stuporous and catatonia. What can you do about this? Yeah. I remember last year within the group, I mentioned about a case that I have dealt with, that the patient arrived in emergency room and he was very agitated, very restless, not unresponsive, but he was confused. He was in delirious state. He was intoxicated of alcohol, of colonia. He used to drink cologne. And I have admitted him to the ward. The next morning, he was found dead. And there was a big inquiry about this, Dr. Walid, because he was, in a way, relative to family somewhere. So there was a big inquiry about that. And I have been interrogated about it. And they asked me why you did not look at the funders in A&E. That will give you some indication to the pupils, how they react. Why you did not check his blood pressure. He was very aggressive. He had visual hallucinations, picking up things from the floor. He will not sit down. Yeah. So what I mean in here, that you need to bear in mind in situations like this, you need to think, you as a doctor, what can you do to ensure that you are doing the best for this individual, the best of care. Yeah. So you can check, you can ask the nurse to help you to check the vital signs. Yeah. Be aware also of stuporous states, sometimes from unresponsive into sudden excitement or sudden irritability or sudden violence can happen in catatonic patients. Yeah. Ask patient to communicate in writing if they are cooperative at some extent. Yeah. I have seen once a patient with Huntington chorea, and she was in very bad movement disturbances, and she was unable to speak, no speech whatsoever, no writing, no. We asked, who is the individual who is too close to her from the home care? And they said, oh, there is a lady who is a cleaner. She was, bring her. And they brought her. And she told us a lot of things about her. So it's helpful always to think in terms of positive outcome of your intervention. You can look at the eyes opened or eyes closed, and we see that very often in clinics where you close the eyes. You may find the patient close their eyes as if there is some kind of attention, but they are trying to mask it. Also, physical examination, neurological exam, if you can. That's what you can do, really. The overactive patient, as I said, limit the assessment to what is important and depends on collateral history also. You need to bear in mind sometimes you might need help and support from other staff, including patients who require restraint. Yeah. Sometimes they might call you for chemical, pharmacological restraint, Acufase, you might give clopixol. Confused patients, sometimes you might find that the testing, the cognition is very important, as we said before. But also, I remember when I was a junior doctor, I have written a paper about that, where I called it the psychiatrist with a white coat, that the psychiatrist should wear the white coat and have the stethoscope and the fundoscope all the time. If you are in clinic, in your own clinic or inpatient. Yeah. Always, if you have this kind of confusion with the patient present with, try to ask about deliberate self-harm, taking an overdose or other materials, illicit drug abuse, intoxicated level of alcohol also. Yeah, I finished, Walid.
يمكن.
Do you want to answer the question about the delusions?
شكرا جزيلا. بعد سؤال الديليوجن بيسان تجاوبين.
false fixed belief.
مهم.
Yeah.
هو كان في في الإجابات false fixed belief أول واحدة تقريبا.
لا، هم في 3 إجابات للديلوجنز.
ممكن بس نرجع نحط بس الصورة.
ممكن. يا خليني أحطها.
الأولى A صح وB صح. وبرضو C اللي هي shared delusion ممكن نقول عنها بس برضو لا D مش C unshakable by reasoning و invariably false برضو يبقى هي abnormal belief و often bizarre و they are unshakable by reasoning صح؟
يعطيك العافية.
الله يعافيك.
شيرين شو رأيك شيرين؟
يعني أنا أتفق على موضوع they are unshakable by reasoning و they are abnormal beliefs. هلا صارت يعني ال abnormality of beliefs شوي إنه عادي ممكن تكون normal، يعني ال belief normal، بس قديش ال delusion ال extreme of ال occupation by delusion وال act upon ال delusion هو اللي abnormal، مش ال belief per se يعني. ومش شرط ال content تكون دائما bizarre. it might be bizarre و it might not be bizarre.
يعني أي منهم من A و B و C و D و E
دي
هاي منها
100%
فورس واحدة، كل واحدة لحالها.
يعني دي هي ال 100% true. لأنه once they're shakeable بتصير يعني part of the
مش شرط
treatment.
يكون بس واحدة، يعني كل واحدة جاوبيها true or false.
They are abnormal beliefs.
true or false.
True.
طيب.
Their content is often bizarre. يعني true بس ممكن يكونوا مش bizarre بس
ما
they're
هو
often
often
bizarre.
ما قلناش always.
أوكي معناته true. The belief
طيب.
may be shared by those of similar cultural background. يعني it's not 100% true هاي السنتنس.
كيف if it's shared by people in the similar background.
إلا إذا كانت shared delusion. إذا shared by cultural background.
هلا لما واحد عنا بحكي إنه متلبسه جن وعفاريت وعين وحسد، وكل اللي حواليه عندهم نفس القناعات، يعني إنه هذا جن وحسد، هل هذا بيعتبر مؤيد للديليوجن ولا ضد الديليوجن؟
بعتبر ضد الديلوجن. إذا
ضد.
اللي حواليه مؤيد تكون ضد الديلوجن.
إذن هاي ترو ولا فولس؟ سي. أها.
أنا حكيت ترو بالبداية، أنا غلط. قصدي أنا
لا هو لأنه طريقة هدول اللي إجابتهم ترو فولس. شو واحدة؟
دي it's true. They are unshakable by reasoning. و the beliefs are invariably بس مش مبين عندي بعد ال invariably.
فولس. invariably false.
This is false.
ليش؟
لأنه ممكن يكونوا true beliefs، بس زي ما حكيت أول إنه هي كيف الانديفيدوال بتصرف upon هاي البليف هي اللي خلتها delusional، مش البليف نفسه هو الديلوجنال.
إنه كيف يعني توصل للبليف.
نشوف الدكتور أمين شو رأيه.
والله الحقيقة إنه يعني أنا سمعت الدكتورات شو بيحكوا. we need to be careful about the language in English. يعني لما يقولوا they are abnormal beliefs is right. They are abnormal beliefs. Simple statement like this. You don't need to go in a lot of details about, is it normal? Is it abnormal? It's abnormal beliefs, the delusion, which is shared by many people around within the culture that it's abnormal. And this is where the delusion is identified. B, their content is often, you are absolutely right, it's not always bizarre. For example, I have seen a patient recently. He's from Asian background, and he believes that the West have made this kind of corruption in relation to the war, and they are involved in it in some way or other. And he spread these kind on social media, and then, but he's ill also. You see, the fact is not shared by the common people in this country. It's considered to be a delusion. When I heard him saying that, to be honest with you, it sounded, there are some elements of truth in it. But the fact is that it's not shared by the culture around here. It's a delusion. He's ill. He's paranoid. Again, often, it's not always. So often bizarre. It's true. It's true. The belief may be shared by those who are similar. It's false. They are unshakable by reasoning. Absolutely right. Whatever you go to explain to the patient or to challenge them about it, they have more stronger belief that they are right. The beliefs are invariably false. It's false. Because the beliefs are false in terms of delusion.
شكرا جزيلا دكتور أمين على هذا العرض الرائع. يعني أنا دائما بحب أكرر للصبايا والشباب إنه مش مطلوب إنك يعني تعمل هذا السايكاتريك أسسمنت بشكل دقيق فقط وأنت ريزيدنت. مطلوب تعمله حتى بعد 50 سنة من الممارسة، لأنه في حالة ما عملته كثرة الأخطاء، كثرة السهو، كثرة التشخيصات الخاطئة كلها تأتي من وراء السايكاتريك أسسمنت. يعني إحنا ما عندنا تولز، والله صورة أشعة بتشخص لي سكيزوفرينيا أو فحص دم بتشخص لي ديبريشن. أنا التولز تبعي clinical judgment و mental state examination. فلو حفظت السايكاتري كلهم وما بتعرف تعمل proper interview و proper mental state and you يعني تتقن هذا now and forever. يعني أحيانا بيكونوا بعض الزملاء الجونيور بيجلسوا معي وبيستغربوا إنه أنا بمشي very systematic، وبتوقعوا إنه أنا خلص يعني شخصت المريض. حتى لو شخصته، حتى لو إني أنا من دخوله من الباب بحلف إنه هذا مانيا. طيب أنا بدي أعرف مانيا ما ماشي، هذه مش كل القصة. من
نعم
أول مرة ولا 10 مرة، كان ياخذ ليثيوم وكومبلاينت ولا مش كومبلاينت، دخل المستشفيات، عنده مشاكل، معه ملايين وممكن يضيعهم. في عندي مواضيع كتير بدي أعرفها، مش بس يعني الأسسمنت فقط عشان أعرف التشخيص وأعطيها أعطيه أنتي سايكوتيك ولا أنتي ديبريسنت، لا، أنا لازم أعرف الشخص كبني آدم بظروفه. حتى لما بحط خطة، يعني أنا بكون بشوف المريض بكرة ووصل الليلة من اليمن، وبكرة بده أشوفه وأقيمه وأخلص ويرجع وخلص، وبعد بكرة بده يسافر على اليمن.
مم.
مش بس كمان ما عنديش فرصة أشوفه يوم ثاني يعني، أو أعمل
نعم
تقييم ثاني. ففي
مم.
أحيان هذه الظروف الخاصة
ولا
أنا بالنسبة لي نص شغلي، يعني الكاتشمنت اريا تبعي هي من من
نعم
بنغازي إلى البصرة إلى حلب إلى صنعاء إلى
نعم
تكون الرياض إلى الدوحة. فأحيانا بيجي يومين، في ناس بيجي أسبوع، في ناس بيجي 3 أيام، وفي ناس ممكن يرجع بعد سنة، وفي ناس بده بس كل
نعم
6 أشهر يحكي تلفون. فإذا أنا ما عندي يعني الصورة واضحة، كيف ممكن أنا أتابعه؟ وحتى اللي بيكون بده يجي على عيادة ريجولار وهو ساكن قريب والموضوع سهل، مش الموضوع إني أنا عملت يعني الأسسمنت السريع وهو سكيزوفرينيك وأعطيته أنت سايكوتو قصة الخير، القصة أبدا أبدا. هذا يعني مهم جدا. يمكن ناس زي الدكتور منتصر اللي اشتغلوا معي وعرفوا هاي الطريقة بيعرف تماما كم هي مفيدة، وكم يمكن بحالات ريزيستنت ومحول إنها ريزيستنت عند ما وصلت في proper psychiatric evaluation لم يتبين أنها resistant، كان التشخيص غلط،
نعم
كان التشخيص غلط، كان في هايبوثايروديزم، كان في أشياء كثير. ولا لا دكتور منتصر؟
والله دكتور كلام صحيح 100%. يعني قديش الايفالويشن هذا بروبر ايفالويشن ودايجنوسز، ونعرف ظروف المريض والاشياء اللي مر فيها من قبل، والفحوصات اللي حضرتك تطلبها، وحتى طريقة الأسئلة أحيانا. يعني ممكن أنا
مم.
اللي بتذكره، كنت أقعد مثلا مع مريض ساعة، وبعدين يشوفه دكتور ولي، أحكي له مش قادر، المريض يعني صعب جدا، مش عارف أطلع منه إشي.
صح
يكون في طريقة معينة يسأله الأسئلة الدكتور وهي مع الخبرة أعتقد الدكتور. فيعني كلام
طيب
100% صحيح.
يعني هذه عشان الدكتورة صفاء ووسام والدكتورة شيرين، يعني مضبوط كلام الدكتور منتصر. كثير من المرات الشباب بيكون بيساعدوني، باخذوا هيستوري وبتعبوا، يعني ممكن يقعدوا أحيانا ساعة ونص وهم بياخذوا من العيلة وبيحكوا مع أخوه اللي بقطر وبيحكوا، وبقول لك أنا ولا مش فاهم ولا شيء، ما في
مم.
معلومات، التقييم صعب. هلا فعلا يعني اوكي، هلا في حالات بهذا الشكل بتتطلب الاكسبيرينس، بس الاكسبيرينس لا تترك الاستراكشرال انترفيو. سوف اعود الى الاستراكشر انترفيو واطلع هون شو العمليه اللي عملتها عمرك 9 سنين بالضبط. عمليه غده ايش، وين، وشو، ورجيني وين محلها. إيه، يعني هو موجودة هي بالهيستوري بس ما أعطيتش اهتمام. كنت سابقا سقطت عن البسكليت وفقدت الوعي، دخلت مستشفى ولا ما دخلت؟
مم.
كل هاي الأشياء رجوع لتفاصيل في الهيستوري.
نعم
ثم بالمنتال ستيت اللي مش راضي يجاوب أسئلة واضحة، برضو أنا بجاوبه أسئلة مش واضحة.
نعم
في عندك هيك أشياء ما يعني أشياء غريبة، أشياء حتى سؤالي أنا مش مفهوم، ما بيكون مفهوم. شو بتقصد غريبة يعني دكتور؟ يعني ماشي هيك. مرات إذا في واحد ما بيعرفنيش بصير بده يعني يصحح لي اللي يصحح له السؤال. لا، السؤال المقصود يكون سؤال غبي and he will project عليه whatever he is seeing as abnormal. بيقدر
نعم
يقول لي يعني قصدك الخيالات، يعني قصدك الأصوات، يعني قصدك اللي بحس بجسمي، يعني قصدك الجن اللي متجوزني. أيوة بالضبط. إيه، أحيانا بستعمل كلمات إلهامات، تهيؤات، تخاطرات. طبعا تخاطرات هاي دكتور أنت شو بعرفك فيها؟ هذه أنا بس أنا اللي بعرفها. لا، بحب أنا أتعرف عليه. يعني أحيانا هاي بالحالات الصعبة، بس برضو زي ما حكى الدكتور انتصر إنه أنا مضبوط، مو أحيانا بيكونوا الشباب تعب ساعة وساعة ونص، بعدين ب5 6 دقائق بنحل اللغز اللي ما كان باين. هذه طبعا accumulative experience. أكيد الدكتور أمين عنده التكنيكس هاي. يمكن هلا الفارق إحنا بإنه إحنا العدد اللي بنشوفه، يعني ما فيش واحد بيوكي بيعمل عيادة يوميا 6 أيام في الأسبوع على مدار السنة، على مدار 40 سنة. that doesn't happen. بيعمل عيادة مرة بالأسبوع، مرتين بالأسبوع، بعيادة بشوف 4 5 مرضى. إحنا ممكن نكون مثلا إحنا بنداوم 9 الصبح، أحيانا قبل ال9 نكون صرنا شايفين 5 مرضى. هذول اللي إحنا بلندن كنا نشوفهم كل العيادة هي 5 مرضى. ف يعني العدد كبير، هذا بعطي خبرة. يعني هلا مثلا الشباب اللي بيشتغلوا، سواء الدكتورة صفاء وبيسان في غزة، الدكتورة شيرين في عمان، يعني بشوفوا عدد من المرضى قد يكون كبير. هلا هو العدد الكبير بدون تدقيق ما له قيمة. صار كأني أنا بعمل كوبي للأخطاء. العدد الكبير مع proper history proper evaluation هو اللي بيسويك اكسبرت. on the background تكون very updated and scientific. نسمع رأي الدكتور جلال.
شكرا جزيلا يا دكتور، وشكرا للدكتور أمين. هلا بالحقيقة أنا يعني بدي أحكي بس للصبايا. هذا الحكي خلينا نقول ربما تقولوا أنتم إنه نحن بين ما نكون خلصنا اختصاص رح يصير في عنا شيء له علاقة بالنيوروسايكاتري، بالجينيتكس، فرح يوفر علينا كل هذا الشيء. هذا بال20 سنة الجايين شبه مستحيل. هناك كثير من الحكي اللي بينحكى انه الخريطة الجينية وضبط هاي المسائل وعم تزداد العلامات تبع النيوروسايكاتري. كل هذا الحكي لم يصل إلى منهجية الأسسمنت اللي قدمه الدكتور أمين واللي حكى عنه الدكتور وليد. فهذا عمليا يعني ما بصير دقة قديمة ولا بحياته. هذا دائما مهم، لأنه البعد البيولوجي هو فقط بعد من التقييم اللي هو بايو سايكوسوشيال، وهذا البايو سايكوسوشيال سيبقى في الطب النفسي وفقا يعني خليني أقول لدرجة تطور العلم اللي منظورة هي هو تقييم ضروري، وبالتالي التعويل على أنه يصير الحل عن طريق ال- المخبر والتحاليل وإلى آخره. هذا حتى الآن يعني أنا عم بقرأ كتاب لأحد أحد أطباء النفسيين اللي هو المدرسة تبعه هي مدرسة evolutionary approach. فبيقول إنه يعني الناس اللي عم تحكي على الخريطة الجينية الواضحة هن نوع من المشعوذين. فهذا أمر مهم، لأنه كثير عم نشوف يعني حكي عند الشباب إنه رح يضل الوضع هيك، رح تضل الأسسمنت هيك، لأنه بايو سايكوسوشيال بالدقة حتى لو تطور الجانب البيولوجي. شكرا جزيلا لكم.
شكرا جزيلا دكتور جلال، شكرا جزيلا دكتور أمين، شكرا للحضور. آمل أن تكون محاضرة أفادتكم، ويعني أعتقد أنها محاضرة مميزة بطريقة سردها السايكاتريك ايفالويشن. يعني احنا لما عملناها للمقيمين، بذكر الدكتور جلال، عملناها تقريبا بحوالي 32 ساعة. دكتور
تمام.
أمين اختصرها بساعة ونص، فشكرا جزيلا.
شكرا
يعطيك
شكرا.
العافية وإلى اللقاء.
تسلموا، شكرا.
اللقاء، تصبح على خير.